engine running. Absolute genius.
Get this.
Welcome.
This is the show where we bring you
Science.
What that essentially means is
discoveries,
Advances.
Questions. Research.
technology. Unbelievable.
Without further ado,
This is The Naked Scientists. Hello, welcome to The Naked Scientists podcast, the show where we bring you the biggest breakthroughs and talk to the major movers and shakers from the worlds of science, technology and medicine with me, Chris Smith. And this week, what's prostate cancer? And are we getting any better at diagnosing and treating it?
From Cambridge University's Institute of Continuing Education, this is The Naked Scientists.
The former US President Joe Biden recently revealed that he's been diagnosed with prostate cancer that has spread to his bones. It's a stark reminder of a disease that kills one man every 45 minutes in the UK, and yet prostate cancer still lacks the public visibility of things like breast cancer and lung cancer. The wrinkle, though, that doctors are grappling with is that almost every man living to 80 will develop prostate cancer in his lifetime. But the majority will never know, and it will never be a problem for them. And detecting and treating a non-problem can, you could argue, only cause problems, whether from side effects or just the mental disquiet of being labelled with a disease. So, in this programme, we're attempting to get underneath this conundrum, beginning by exploring what prostate cancer actually is, how it spreads, and perhaps most importantly, what's being done to improve screening tools and develop more targeted treatments. Professor Mark Emberton is a prostate cancer specialist based at University College London. I began by asking him who the typical prostate cancer patient may be.
Typically, it's a man just over 65. I think 67 is the most common age that we diagnose prostate cancer. Usually there are no symptoms, and so they have presented as a result of a positive blood test, something we call a PSA, which puts them at higher risk than an average man of their age.
And you say no symptoms. Is that part of the problem here?
It is. Once prostate cancer causes symptoms, you've got a problem. It usually means that the cancer is invading local structures, rectum, which sits just behind, bladder, causing problems with peeing, but that's a very, very late presentation. Or even worse, as we've recently seen in the news, the cancer has spread beyond the prostate to bone and lymph nodes.
And what actually is this cancer? And I mean, as in when one looks at this cancer in the prostate, what is happening? Where's it coming from? And what's it doing?
So the prostate is a gland. It makes semen. None of us would be here if the prostate didn't exist. And it sits just below the bladder and just in front of the rectum. So it's tucked away just behind the pubic bone, the hard bone that you can feel just above the penis. So it's a kind of hard to get at organ. And, the prostate sits there quietly for most of one's life. The prostate can grow in a benign fashion. We call that benign prostatic hyperplasia, and can cause problems peeing, emptying the bladder by squeezing the urethra or the water pipe. Prostate cancer develops in most men over time. And so, if you look at the prostate of men aged 80 who die of something else, you're more likely than not to find small amounts of prostate cancer within that prostate. And that's been known for a long time. We know that the production or the generation of cancer develops over time. What we understand less well is why in some men is that process accelerated and that cancer becomes aggressive and has the capability of spreading beyond the prostate to other organs and resulting in death if left untreated.
What are the risk factors for it? Who's most at risk?
There's nothing you can do to prevent it. It's not linked to smoking or alcohol. But we do know quite a few things. Maleness, obviously, is critical. Age is hugely important. And I think age gives the cancer the opportunity, or the cells in the prostate, the opportunity to undergo sequential genetic mutations. So, these are little kind of errors where the DNA is copying itself. And we know that prostate cancer, there's not one error that results in it. It's usually lots and lots of little tiny errors that probably accumulate over time. We do know a little bit about epidemiology, so the kind of the big picture stuff. If people move from an area of low cancer incidence, such as South Asia, and move to America within a couple of generations, they approximate the risk that we would normally associate with Americans. Black men, for instance, are at greater risk. We don't exactly know why that is. It may be genetics, but we don't understand that fully. It may be lifestyle issues, diet. It may be, vitamin D through the inability to, or the reduced ability to absorb sunlight. But it's ill understood, and that's pretty much about it. There's a kind of interesting move, as you move away from the equator, the especially in the northern hemisphere, the incidence increases. So there's nothing you can do to prevent it, and therefore the only strategy we really have is to detect it early.
And what sorts of numbers are we talking about? If you take a country like the UK, although you've said it's very, very common with age, presumably we've got an ageing population, we're seeing more cases, but how many cases do we get and how many men die every year because of this?
It's very common, but fortunately not many men die of it. So that's the kind of really important bit of news to take out of this. But having said that, about 1 in 8 men in the UK today will be diagnosed with prostate cancer during their lives. About 12,000 men die every year. The good news is that the death rates have reduced over the last decade by about 10%, largely due to improved treatments. There has been a dramatic improvement in the way that we manage prostate cancer throughout, from the moment it's diagnosed to very, very late disease. We used to say that a man had a kind of 3% lifetime risk of dying of prostate cancer. So I'm 1 in 30 risk of dying of prostate cancer during my life. That's probably now to kind of close to, not quite, but close to a kind of 1 in 2 risk of dying of prostate cancer during life. So huge discrepancy between prevalence, which is very dependent on how we define the disease, and the proportion of men that will die of it.
Why do you think, given that it is so common, that we don't have a programme for screening for it in the same way that we have a programme for screening for, say, breast cancer or cervical cancer?
So we've tried many times, UK, USA, big screening studies, hundreds of thousands of men have been randomized to an early detection program versus standard of care. And the results have been very disappointing.
Was that what, people didn't live any longer, or we over-treated people?
Yeah, you can in some studies. Many studies showed no difference in mortality. Some studies have shown a very small difference. So men who are screened have a lower chance of dying of prostate cancer, but at huge cost in terms of the number of men that are biopsied and the number of men that are probably overdiagnosed. Very difficult concept, but this is somebody being given a diagnosis that will have no impact overall on their survival. And so I think there's only one country in the world that has a formal screening program. I think that's Lithuania, but there are no other countries in the world that feel that the evidence is sufficiently compelling to implement a screening program in the way that you've suggested. And I think the reason for that is we've been using the wrong tools. We've been using the tools that we had, PSA, and a rather inaccurate form of biopsy. All the studies have been done in that manner. And we're just now poised to start seeing if we can detect cancer early using today's tools, which are very, very different.
And a bit later on, Mark and our other contributors will be telling us a bit more about what those new tools are and the impact that they can have. That was Mark Emberton from University College London. As Mark said, for many men, prostate cancer develops silently, and by the time any symptoms appear, it's often very advanced. This is because there's no single definitive test for prostate cancer. To date, one test that we have relied upon heavily looks for a protein biomarker called PSA, that's prostate-specific antigen. It does indeed have its uses, but some dub it a poison chalice, owing to its potential to mislead. So why is this, and how reliable is it? Well, I went for a wander across the beautiful Essex countryside with Vincent Yanapragasam, who's a professor of urology at the University of Cambridge.
The PSA is a protein produced by the prostate gland, primarily to keep sperm healthy. It stands for prostate-specific antigen. The relationship between that and prostate cancer was found back in the 80s, and really was observational that the levels were high in men who were presenting with prostate cancer. And it really took off in a major way and now has become the de facto test for prostate cancer. But it's not really a test specific for cancer, it's more specific for the prostate, shall we say.
So does that mean lots of things could make it high, not just cancer?
Perhaps not lots of things, but certainly infections, inflammation of the prostate, enlargement of the prostate will all cause the PSA to go up, and certainly prostate cancer, of course.
How do you disentangle them then? If you've got someone in front of you and the only thing that's been measured so far is this blood test and it's high, how do you decide what that means?
Well, this is the conundrum, and this is why, of course, screening and testing for prostate cancer has been so controversial. Generally speaking, a high PSA would be associated with prostate cancer, but high is a very variable thing. No doubt, when you get into levels of the tens and the hundreds and the thousands, it's almost inevitably going to be prostate cancer, but it's much more nuanced than that. In terms of what does high mean, lots of people have tried to attempt to answer that, and so we have this idea or concept of the age reference PSA, which, to be frank with you, does not have a lot of scientific validity or basis, and the age reference levels of PSA have changed and they continue to change. In the UK, for example, up to a few years ago, perhaps even now, depending on where you lived, you might have a different PSA age reference. So the concept of high is based on a cutoff which has been ascribed to some epidemiological studies, but really is open to interpretation.
How should someone proceed then? If they're my age, I'm just over 50, and I don't know if I have any risk factors for prostate cancer, but how would someone like me be advised by someone like you to go forward?
So I think, putting aside the conundrums, let's talk about practicality. If you were over 50 and you had a PSA, and based on the PSA reference range in your area or in your practice, then you'd be referred up to the hospital. And that would trigger a line of investigation. Things have changed tremendously in the last, say, 10 years or so, because at one time a raised PSA would have led straight to a prostate biopsy, which is a procedure to take samples from the prostate. Now you'd get an MRI scan first. And this has been very useful primarily to reduce the chance of biopsying the prostate, which may not harbour something. And that's what would happen now.
Is that any good? When we scan people, does that help?
There's no doubt that if an MRI is done and it comes back showing that there's nothing to see, then if you did proceed to a biopsy, chances are you wouldn't find prostate cancer. It's much more nuanced than that, and certainly a negative MRI does not absolutely mean there's no prostate cancer. On the other hand, if you do an MRI and the radiologist reports as an area of concern or something like that, then that would be a strong trigger that we should go and look further.
So someone finds themselves in this position where they have a high PSA, they've had a scan, it shows there's a lesion there, there's something in the prostate which looks like it could be a cancer. What next?
That's where the prostate biopsy comes in. And that's a procedure, local anesthetic, where a needle is put into the prostate and we take samples. The diagnosis of prostate cancer remains one of a histological nature, which means from the samples, not simply from an MRI scan.
You've got those samples then. How do you decide from those biopsy samples how severe that cancer is, how aggressive it is?
So the first thing is, if we take a biopsy and there's prostate cancer in them, our histopathology colleagues look at it. And if there's cancer there, they'll give it a grade. And that grade goes from a 1 to a 5. 1 is the least aggressive, 5 is the most aggressive. But that is only one part of the assessment. We then need to consider what the PSA level was, and we also need to say, what did the MRI scan show? This time not whether there's a lesion or not, but is that area in the prostate which the biopsy seems to suggest is prostate cancer confined to the prostate, or is there any signs that it's actually breached the lining? Now, when we put all those things together, then you can derive something called the Cambridge Prognostic Group, which is the nice UK standard for classifying prostate cancer, which has not spread. So, two distinct ways, both of which are complementary. The biopsy tells us the grade, and there are 5 prognostic groups. Each will tell us what the chances are that that individual will come to harm, in other words, mortality, from that prostate cancer diagnosis.
Vincent Yanabragasam from the University of Cambridge, and we'll hear a bit later on from Vincent how we can use that information to select the optimal treatment for a patient's disease, which might actually include doing nothing, at least for a while. This is the Naked Scientist podcast with me, Chris Smith. This week, under our microscope, is the subject of prostate cancer and what science is doing to help us become better at telling who has it and who might need treatment. Now, as we've been learning, a big part of the problem with prostate cancer is that we don't have a simple solid test for the disease. PSA, prostate-specific antigen, can be misleading, and even if it does detect a cancer, it can't tell us who's at high risk and needs intervention. Instead, it triggers a slew of costly follow-up investigations. So can we improve on this? Well, a team in Cambridge think they can. Rather than rely on one single marker, they've used machine learning to comb through hundreds of molecules and markers, integrating genetics and clinical outcomes to spot patterns of changes in a carefully chosen 100 of those markers that, when considered together, can more accurately, they say, predict prostate cancer outcomes. The company is EDX Medical, and they hope to have the technology in front of regulatory bodies within the next 12 months. I've been speaking with founder and scientist Sir Chris Evans, who explained how it works.
It's what it says on the tin. It's a super test. The aim was to look at a whole cluster of diverse biomarkers clinically linked with prostate cancer or the stage of prostate cancer. And we finally narrowed it down to 100 and odd markers, those being hereditary genetic, mutation, epigenetics, transcriptomics, RNA, and proteomics. And we now look at all of those biomarkers in a single sample of blood and urine from a single man at a single point in time.
As we've heard in this programme already, though, the issue with prostate cancer is often determining who has prostate cancer and it will cause them a problem versus who has prostate cancer, it is largely innocuous and will never cause them a problem in their expected lifetime. So can your test tell those two apart?
Yes, there are sufficient biomarkers in the categories to actually characterize, first of all, the result. Cancer is present. The second is this cancer is very aggressive. And it's aggressive for these reasons because of these biomarkers which have lit up. Or your cancer does not appear to be aggressive. We have not found the aggressive biomarkers we were looking for, or they are very low levels. And then thirdly, the type of prostate cancer you've got. So that again may influence how we decide to treat this and monitor this disease going forward.
So this would move us into a regime of what some surgeons and urologists are dubbing a sort of active monitoring state, where you can pick up the disease because you can gauge how aggressive or serious it is. You feel more confident saying, well, in this instance, we're not going to need to do anything at this stage. We're just going to watch. So can you do that active management where you just keep an eye on people, monitoring them with this test over a period of time? And then if the tumour does evolve and show changes or it switches to a more aggressive type, then that would trigger a different kind of treatment.
Yes, this test would be a brilliant monitoring test because it will pick up all those different characteristics as the disease progresses. So there's no question. And it can save quite a lot of time and money from having repeated MRIs and particularly biopsies. And if our blood and urine tests can readily, annually or biannually generate data which is clinically significant and very reliable, that information will be maybe all that these consultants and the doctors need to see.
How have you validated this? And by that I mean, as in, how have you compared what your test says about a patient compared with what the other methods we currently have or long-term follow-up says is going on in that patient to prove that your test is getting it right?
We need to go through at least the next 12 months of validation trials because we've done sufficient work to know that the test works, okay? So we take 10 patients, knowing 4 of them got cancer and 6 haven't, we would get that right almost 100%. But in terms of comparing the diversity of people to start with, in terms of ethnicity, their age, the other phenotypic problems they have or don't have, and then the different types of prostate cancer that could be present and the different stages it could be present, we need to validate that through the trials that we're now carrying out and submit all our findings to the MHRA and the FDA and get approval to sell our test to all and sundry, but particularly and initially to the private markets.
One of the most important mantras in cancer is early pickup, because the earlier we're able to intervene, the earlier the disease is in its course, the less likely it is to have gone anywhere, the less likely there are to be consequences and side effects of the treatment.
Yep.
So how far forward do you think with this test you might be able to bring early pickup?
Early stage diagnosis at the very, very earliest stage is the ultimate holy grail, so that you can pick this thing up when it is ideally a single primary tumour in its smallest size before it's started doing anything else sinister. We know that our biomarkers, and particularly multiple biomarkers, can do that, where you've got multiple biomarkers and multiple categories of completely different biochemical biomarkers, albeit genetic as well as protein, epigenetic, transcriptomic. You're increasing your chances of picking up the things you need to pick up at the very early stage.
And let's look at some numbers then. How good is it if we look at the accuracy of picking up, telling cancer from not cancer first? Just tell us, what is that number? If I give you a sample from a person, what's your ability to say cancer or not?
What we've seen in terms of specificity and sensitivity, our figures have all been between 94 and 96%. And we've even seen categories as high as 99%.
So it's a good rule-out test. If you find it, you're saying to someone, there's a high likelihood this is a genuine cancer or not. So that's really good. When you find a cancer, what does it look like in terms of its ability to predict whether this is a watch and wait or escalate this through imaging and then possibly other kinds of treatment?
Based on all of the samples we've done so far, you're talking of 90% again. These figures of about 90% means, you're getting nearly 9 out of 10 blokes right in terms of what you're trying to do here, whether cancer is present or not, and whether it's early stage or not, or whether it is aggressive or not. Now, we need to do quite a lot more computing work on the very aggressive stages versus the less aggressive cancers to publish the accurate number.
But I mean, this is the issue that really matters, though, isn't it? Because at the moment, the diagnostic quandary is we can use PSA and we can find cases, but we then struggle to decide how best to manage these people. Many, many people don't need anything other than just being watched, and they're going to have no problem with prostate cancer despite having prostate cancer for the rest of their life. Others need escalation of their treatment, and this is the issue which we really struggle with, isn't it? So do you think, although you're very good at finding cancer and ruling it out, do you think that you're going to be able to crack this nut with this test?
To be fair, we're all leaping ahead here, because I did discuss this with another clinician who made the same point as yourself. And I said, well, that's great. You're talking about PSA, which is what he's using now. And I said, if I give you 1 million samples, 1 million men, where they've all got very low PSA readings, you're not going to do anything. You're not even going to monitor them. You're not even going to screen them in the MRI. He said, correct, sir. And I said, and 130,000 of those men will have aggressive cancer. That's a fact. I said, but it's worse than that, isn't it? Because of those 1 million men with positive readings, if you've got 1 million positive readings, you're going to run all these 1 million men through all sorts of MRI and possibly biopsies and panic stations and weeks of waiting and anxiety, guys going on Prozac, etc. And 810,000 of those 1 million men actually don't have prostate cancer. So I'm afraid you need to stop hundreds of thousands of men going for MRIs and biopsies unnecessary. We need to be able to pluck them out and feel confident that the ones you send in for these MRI scans are worrying patients.
It's an important point, isn't it? Sir Chris Evans at EDX Medical there. So having found a prostate cancer, we return to that question of what we need to do about it. For cases of advanced disease where the cancer has already spread, there's broad agreement about the best management, which includes approaches like chemo, radio and hormone therapies. But it's how to manage the majority in the middle, men with early stage local disease where the path of opinion divides. Some advocate for a surveillance-based, minimally invasive approach, empower people to monitor themselves and only escalate the care as required, pointing to no differences in mortality and fewer risks from intervention as a result. Others argue for early intervention with tissue-sparing approaches like focal surgery to remove the disease locally but leave the prostate intact. Mark Emberton, whom we heard from earlier, is a strong proponent for early pickup and intervention.
Now we've got this thing called imaging or MRI. So if somebody is at risk, the first thing we do now is see if we can see the cancer. And now if your MRI is normal, we reassure the patients and discharge them back to their GP. If the MRI is abnormal, then we have two options. We can watch that lesion. We call these things lesions. So these are little nodules within the prostate, or we can verify its nature by putting a needle into it. And the big difference to 10 years ago is that needle is now directed into the heart of that lesion. So it's very, very likely to give us the ground truth of what's going on in that lesion. Is it a benign process? Is it inflammation, or is it cancer?
So you can map the coordinates, as it were, of where that abnormality is based on the MRI scan, and you can say that's where I want the biopsy from, and that's the breakthrough, to your mind.
It's a huge breakthrough in terms of the precision of the biopsy process. And we use lots of kind of complicated computing now to import the MRI images onto the ultrasound. There's a bit of AI involved in that. And so the biopsy process has gone from a very imprecise, unreliable, dangerous test, it's done through the rectum, infection, bleeding, etc., to something more like a brain biopsy.
Okay, so let's say someone has that and the news isn't good. The biopsy, I suppose in some respects it's good news because it's found, but the biopsy is positive. There is a prostate cancer there. What are the next steps?
The histology will confirm the cancer. So the histology is when we look down the microscope at the tissue that we get from the biopsies. Like most cancers, there are cancers that behave pretty well, and there are other cancers that have features that we know are associated with a very aggressive clinical pathway. And we grade them. And then with that information, we make a treatment decision. If we deem the individual to be low risk, we can watch the disease because the risk of progression is low and the risk of death over 10, 20 years we know to be low. If the cancer is high risk, we tend to offer quite a bit of treatment. We call that multimodal. So it might involve surgery, it might involve radiotherapy, it might involve chemotherapy, hormones, and these days immunotherapy. But most are in the middle. And those men will be offered either surgical removal of the prostate or radiotherapy to the prostate. The other big revolution that imaging has given us is the opportunity to just treat the cancer plus a margin in the same way that a woman might have a lumpectomy or somebody with a small lung cancer might have the cancer removed plus a little bit of that lung lobe. And that's transformed things because we can do that without the usual harms associated with surgery and radiotherapy. And moreover, that can be done as a day case.
There are side effects of these interventions, though, aren't there? And in men, we worry about impotence, for example, big concern for especially younger men. Also, disturbance of ability to pass urine the normal way. What are the outcomes like? Now we've got this better imaging, more guided therapy. Have they improved? And a man having this sort of intervention, what outcome can he expect?
Yeah, no, you're absolutely right. So the problems associated with the traditional treatments have been kind of collateral damage to surrounding structures, bladder, urethra, the vessels and nerves that serve the penis, that drive erections, the rectum behind. Radiotherapy, although it's got a lot more precise, can still cause collateral damage and cause symptoms as a result. Removing the prostate means that at least one of the sphincters, the things that keep you dry, is removed, and then you're reliant on the sphincter that you can initiate, so the one that we can control. About 10%, sometimes more, will leak urine and require a pad. The big problem with surgery is, and indeed radiotherapy, has been the impact on sexual function. And many, many men will lose the ability to get and maintain an erection. And that's largely due to damage to the vessels and nerves that are required for erectile function. The new treatments obviously preserve those structures by limiting the treatment just to the cancer and a margin around it. And we can now avoid incontinence completely. So I quote 1% now for a focal treatment, and 90 to 95% of men will preserve erections sufficient for penetration. So a dramatic improvement in the kind of long-term quality of life aspects of care.
Mark Emberton at University College, London. Vincent Yanapragasam at the University of Cambridge, on the other hand, believes that immediate treatment may sometimes do more harm than good. His data show that active surveillance, where you keep a watchful eye on a patient and act only when prompted to do so because tests show that the disease is evolving, have the same outcomes for mortality as early interventions, but they don't have the risks of treatment side effects. This protocol has actually now been embraced by Ireland as their standard of care.
If you have disease which is of a poor prognosis, almost inevitably you will need treatment, and those men are directed towards curative treatments that could include surgery or radiotherapy. If you have disease on the better end of the spectrum, then here is where the real conundrum comes as to what is the best thing to do. Because prostate cancer by and large is not a lethal disease. It is a disease with a long natural history, and actually they're all saying that most men will live with prostate cancer and not die from it. It's absolutely true. So what we do is we'll give the odds. Now here, it's really important to understand the other factors in that person's life. What other illnesses do they have? How old are they? And we present the data about the value of treatment benefit. Now, once a man has that information, they can then make informed choices and decisions about whether or not to have treatment, or, very crucially, go into a program of active surveillance or monitoring, which means that we keep an eye on things with regular blood tests, interval scans, perhaps repeat biopsies, and if in future things change or progress, then we can treat. And that approach has been shown to be as good as treating someone up front without all the risks and side effects and all the problems.
That is something you've been pioneering, isn't it? I mean, that's an approach that you've developed where you've said, well, let's compare people who we do an active surgical intervention with people where we keep an eye on things. And what is the outcome of that? If you compare people who have one or the other, does one group do better?
Now, it's not about doing better or not, because actually we know the outcomes are the same. In other words, the chance of survival is pretty much the same, very small differences. It's about whether or not we're doing any good with a treatment up front, or whether surveillance is the best thing to do, and then think about treatment if necessary.
So you could actually be doing harm then. If you were to go in and do surgery on those people who would do as well as if you left them alone, then really they could come up worse off, couldn't they? Because of all the risks of surgery for no clinical benefit.
Absolutely. And
although I suppose there could be a psychological one, having said that. If I know I've had the area that was detected as abnormal removed, that makes me feel better mentally.
Well, first let me address the issue of the effects of treatment. So any treatment, no matter what it is, whether it's radical whole gland or other types of treatment, has the risk of side effects. And we know very well that a lot of men who get treatment for early disease actually will gain no survival benefit, but will have all the after effects and problems of the treatment. And really, my mantra has always been treat something if it needs to be treated, but don't treat it if you don't need to treat it. We have very robust surveillance and mechanisms which work extremely well, which we have shown and published. And that is what happens to men who don't need immediate treatment. Now, regarding this aspect of psychology, I think that if a man continues to be anxious about a prostate cancer diagnosis after they've been through our clinic and process, then it's a failure of counseling. What we should not be doing is trying to give treatments which, if you like, palliate psychological anxiety, both on the part of the patient and also the clinician, urologist or oncologist. That is bad medicine. It is our duty and job to actually give the information that explains to an individual why something needs to be done. And one of the biggest things that I find in my practice is we get a lot of men who come to us, and a lot of men who will say, well, what would you recommend? Because they want someone to tell them, and they find it very strange we're not doing that. But of course, the whole reason why we don't is because we know very well that we are likely to do more harm than good, and that probably this prostate cancer may never affect them.
Is there not a problem, though, Vincent, that as you go further on down this path, given the ageing population, and given a watch and wait strategy that you're advocating for, you're going to accrue a massive list of people that you're keeping an eye on. Can we resource that?
Active surveillance has been very badly resourced. No one is interested in it because, well, it's not very exciting for a lot of doctors. but it is crucial for patients. So we have developed a very structured surveillance program which actually empowers the patient to self-monitor. So we give them the tools to do this. So each patient on our surveillance program is given a particular regime of follow-up, what to expect. We also tell them how to do their PSAs, what to look for. We find that actually we've managed to increase our active surveillance population without actually having to increase our clinic footstamp.
I read that this has now been embraced by Ireland. This is their de facto way of doing prostate management, but not the UK.
Well, not so far, Chris.
But why not?
Well, I think you'd have to ask NICE about that. We are planning to approach them to present the evidence and the data. And one of the problems with active surveillance is that it's been rife with opinion and it's been rife with variances in practice. I often refer to active surveillance in the UK as the Wild West of prostate cancer management, because whereas you have high quality standards for surgery or radiotherapy, you can measure what's happening and you track patients. In surveillance, no one does that.
But we strongly suspect that is going to change. Cambridge University's Vincent Yanapragasam there. I've learned a huge amount over the course of this programme, especially that the management of prostate cancer is a field that's changed enormously over the last 2 decades since I learned about it at medical school. Much of that change has been driven by new technology and imaging techniques, and as new tests like the one being developed by Chris Evans come on stream, it's inevitable that our approaches will be refined further. The ultimate goal must be, though, the earliest detection together with the most accurate prognostication, and sometimes not being frightened to do nothing at all. Next time, the mental health crisis among the young and what a new hospital concept aims to do about it. The Naked Scientist comes to you from the University of Cambridge's Institute of Continuing Education. It's supported by Rolls-Royce. I'm Chris Smith, and from all of us here at the Naked Scientist team, thanks for listening, and until then, goodbye.